Kia ora koutou, nau mai haere mai to tonight's Goodfellow webinar. My name is Katie McCulloch and I'm a nurse practitioner working in Tamaki Makaurau. Tonight we return to the Te Tiri Whakāro Sharing Knowledge series, which is created in collaboration with Whatu Ora. Tonight's webinar is going to focus on H.pylori and fecal immunochemical testing for symptomatic pathway. Dr. Cameron Schauer will be discussing updates in the management of H.pylori, and Drs. Ralph Van Dalen and John McMenamin will provide an overview of the fit for symptomatic pathway. We will follow up with our standing segment of clinical updates with Dr. Tutty. So our first speaker tonight is Dr. Cameron Schauer. Cameron is a gastroenterologist working at the North Shore and Waitakere hospitals and in private practice at Waitemata Endoscopy. He's a clinical lecturer at the University of Auckland, and he's currently undertaking a PhD on testing, identification, and treatment of H.pylori in primary care, with future directions of population-based management. Over to you, Cam.
Kia ora, everyone. Thank you so much for having me here. I'm really excited to be able to give an update on H.pylori and the full spectrum and the full gamut, which I've been extremely passionate about for a very long time. And I think when folks think about H.pylori in primary care, secondary care, tertiary care, I think the first thing that strikes me is that we say, do we actually have a problem? And H. pylori, immediately you think of dyspepsia and then possibly the worst outcome, gastric cancer. Gastric cancer outcomes in New Zealand, you can see here, are far less prevalent in, for example, colorectal cancer, which hogs a lot of the headlines, and perhaps rightly so. When you compare this to some other countries, for example, Asian countries, Korea, Japan, China, massive disparities there. In particular, gastric cancer, which is the second most common cause of cancer in Asian countries. 13% of their cancers in Japan are gastric cancer, very large volumes. So because of this passion, and as you've heard, I'm super fired up about this, so much so that I'm started doing a PhD on this last year as well, as I went to Japan in 2019 on my fellowship to see how do they crack this problem over there when they've just got these overwhelming numbers of cancer cases in H. pylori. And so I learned from all of these good folks here who come and peer over your shoulder and ooh and ah and gasp as you perform gastroscopies to try find these gastric cancers that are all driven by H. pylori. And you can see here on the x-axis of this graph the H. pylori infection rate, which increases down on the right side, and gastric cancer incidence. And there's sort of a very clear correlation. The higher the H. pylori infection rate, the higher the gastric cancer incidence. You can see here in particular Asian countries, like I mentioned, but other European countries as well. When you decide to intervene, and as the Japanese have done in 2013, and they arranged for a national screen and treat program of H. pylori, massive drop-off in, obviously, H. pylori cases, but massive drop-off in gastric cancer rates. And they're really reaping the rewards of this that has been going on for 10, 20 years or longer now. But in New Zealand, you might be thinking, gosh, is this all a storm in a teacup? And what's this bloke going to talk to me about that is sort of relevant here? So I really want to go through a sort of a 3-step plan here. What are the symptoms that you see, that I see in practice? What about diagnosis, treatment, and retesting? Well over 82% of the H. pylori diagnoses made in New Zealand are made in primary care. How were these made? How should we be testing for it? And what about the future? And in perhaps 4 to 8 years after my PhD is published, I'll be able to answer some more of these questions. So the first thing really is that it's important to note, and perhaps why some people think it is a bit of a storm in a teacup, is that the majority of folks with this condition are asymptomatic. This is the most common bacterial infection in the entire world. The vast majority of people will not have any issues. But there's a spectrum, as we'll know, from dyspepsia, which is a whole separate talk in its own right, but is incredibly common with very high morbidity, of course, very low mortality, but incredibly disabling for many patients. 80 to 90 or more % of ulcerations are due to H. pylori in the GI tract. And to keep GPs awake after a long day practicing, they said, include a nice video of a squirting ulcer. We've got cool things in gastroenterology that we can use, these heater probes that we can grab these vessels and burn and fix these ulcers. But thankfully, with identification of H. pylori, a lot of these ulcerations are becoming a lot less frequent, and our sleeping at night is getting a lot better. But gastric cancer is something that I think is worthy of note here in New Zealand. 90% of gastric cancers, of non-cardiac gastric cancers, are due to H. pylori. H. pylori increases your risk of gastric cancer by 3 times. And this is a big problem worldwide. I've shown you that perhaps not in New Zealand in terms of case number and volume, but I want to show you about the inequity here. So worldwide, massive numbers. In New Zealand, less so, but still important and increasing. In Asian patients, and in Auckland, for example, where I practice, nearly over 30% of the total Auckland population and growing is Asian from immigration. So this is something that we are going to have to learn to understand and manage. Importantly as well, in Māori, this is the 5th most common cancer. There's a 6-time incidence of gastric cancer when you compare to non-Māori patients, and a 4 times higher rate of hospitalization for ulceration. And most shockingly to me, the age of diagnosis is 10 years younger in Māori, but they're still 22% more likely to die than non-Māori. And we know that 50 to 66% of this is driven by H. pylori, of the excess cancer death is driven by H. pylori. It's very infrequent that you can sort of distill it down to one factor. In terms of diagnoses, there's been a 40% increase in testing in the last 6 years. The most common test ordered in New Zealand, of which 82% are in primary practice, is serology, or the blood test. It's probably an area of convenience. Serology is very difficult to interpret. It's not suggested, particularly in high-risk patients, Māori, Pacifica, Asian, very difficult to interpret. Many duplicate testing. In fact, of all of the duplicate testing, 50% of those were serology testing, because there's a lot of confusion when it comes to serology. Oftentimes, patients that have had Helicobacter pylori will remain serology positive for some time, which can lead to multiple rounds of unnecessary eradication. Urea breath tests aren't done in New Zealand frequently, and maybe it should. That's going to be part of my work that I'm doing or looking into. And this is a very convenient thing that's frequently done overseas. It's very accurate. But the fecal antigen, folks, is the key here. Very high sensitivity and specificity. You do have to stop omeprazole for 14 days to get an accurate result. If folks have got so much dyspepsia or reflux or otherwise, using famotidine. Ranitidine is about to come back on the market, but famotidine currently 20 milligrams twice daily or once daily can be used as a substitute. That's a histamine receptor blocker whilst you're doing the fecal antigen test. Fecal antigen is the only, to make it simple, is the only really diagnostic test that should be done. That's a very well established here in New Zealand. So what's actually happening in New Zealand? Andrea Teng and her group from the University of Otago just published their results on nearly 90,000 tests in the northern region, which is nearly 2,000 folks. And they looked at all the patients that had their first test for H. pylori from 2015 to 2018 inclusive. The testing rates here, so these are odds ratios comparing to Europeans, which is one. So if you're Māori and Pacifica, the way to read this is that you've got a 20 to 30% less chance of having an H. pylori test. Asians and Middle Eastern, Latin American, African, you're twice as likely as a European patient to get tested for H. pylori. 22% of all first tests for H. pylori were positive. You can see here that these patients are highly likely to be positive, 3 times more likely if you're Pacifica or Mila. Māori, Asian, also highly likely to be positive. What about treatment rates? If you're Pacifica, you're 10 times less, or you're 10% less likely to be actually treated within 6 months for your positive H. pylori test. Retesting, and I've got a slide on this. 34% of all these folks that were positive were retested. 30% of those that were retested were still positive, and many folks there, you can see 24% sort of missed out on treatment despite being positive again. So some folks are falling through the cracks, and possibly a lot of patients. What's the likelihood of being retested? If you're Māori Pacifica, you can see that you're a lot less likely, 50 to 60% less likely to be retested, 40 to 50% less likely to be retested if you're Māori Pacifica versus if you're Asian, 30% more likely to be tested than if you're European. So what we have here in New Zealand is a bit of a Swiss cheese, where Māori Pacifica have got the highest prevalence along with Asian patients of H. pylori. They've got the lowest rates of testing. And even if you are so lucky as to be tested, you've got the highest rates of them being untreated for your positive test. And even if you are treated, you're almost the least likely to be retested to check for eradication. And that is probably what's leading to those massive inequities that I've mentioned. So again, diagnosis, fecal antigen test. I'm hoping to see in the future that those graphs of serology drop off and drop off and drop off. You do have to be off PPI for 2 weeks. H. pylori, the diagnosis, is very, very rarely an emergency. Only test it if you intend to treat the positive test, and only treat for confirmed eradication. Even in hospital with a large ulcer, I wait for the positive test to return. I don't eradicate empirically, because the eradication program, as I'll show you, is really important to get right for the first time. So leading on to treatment here, triple therapy. What is this? In that study that I just mentioned of nearly 90,000 folks, 80 to 85% of patients that were treated had it as per the guideline. The guideline here is omeprazole 20 milligrams a day, amoxicillin and clarithromycin. I suggest to use 40 milligrams twice a day of omeprazole. I guess that to some might be semantics, but really, you really want the pH of the stomach to be between 6 and 7 to have the highest likelihood of the antibiotics and the working to kill the bacterium. And the omeprazole is really causing the least amount of side effects from that regimen there. How long should you do it? Definitely not 7 days, either 10 to 14 days. The folks that weren't sort of adhering to the guidelines were oftentimes 7 days. I say 10 to 14. The guidelines have sort of now been updated to 14, 10 to 14 days. The clarithromycin resistance rates are high in New Zealand. If they've had macrolides recently, like a zithromycin for an upper respiratory, lower respiratory tract infection, think about using a substitute, because it's highly likely the patient will be resistant to clarithromycin. Very low rates, as I'll show you, of amoxicillin resistance. Many folks will suggest they've got a penicillin allergy. You can go to this PenFast test to really see if it's safe to give folks amoxicillin. If you're not giving patients with H. pylori amoxicillin as part of your treatment, the risk, as I'll show you here, is really high of not eradicating first line. You can see here clarithromycin, metronidal, amoxicillin resistance, quite considerable. I'm going to update all of this with more robust data from New Zealand as part of my work. We're about to start recruiting patients into this. Quadruple therapy, as you can see there on the left, is difficult. 4 times a day tetracycline. You can't or shouldn't substitute doxycycline for that. That's a special authority medication, tetracycline. Bismuth makes you feel sick. Metronidazole makes you feel sick. It's really difficult. So anticipatory guidance is something that I think is really important here. I tell folks that the number one cause for inadequate or failed eradication is missed doses. You should expect to feel unwell from the treatment. If you tell folks that, they'll be happy with you if they don't. They oftentimes feel quite nauseous. Sometimes folks want to take probiotics. There's no good evidence for it, but it doesn't cause any harm. Smoking reduces the efficacy, so sometimes it's nice to sort of quickly mention that if you have time. And I tell people the rationale for this, and that can sometimes really gee them up to take that volume of tablets to treat this. Sort of running out of time here, but special groups, if you fail first line and second line treatment, third line is referred to secondary or tertiary care for a gastroscopy and biopsy and culture. Reinfection in New Zealand, we think, is very rare. If you treat them well and confirm eradication, less than 1 to 3% reinfection rate, we think. Children less than 18, people will always ask this. Very unlikely to be causing any pathology. Avoid it if you absolutely can. Pregnancy, similar. After 14 weeks, it's sort of safe, but really there's a lot of dyspepsia and other symptoms in pregnancy, very unlikely to be related to H. pylori. Avoid it if you can. Finally, getting to the end, retest. Should you retest? Absolutely, you should. You need to be off. You need to have finished the dose for 6 to 8 weeks after your eradication regimen and be off PPI. This currently in the Auckland guidelines says that you only should retest if you have dyspepsia. We're currently writing a compelling article to get that changed to absolutely we should be retesting. Very finally, in other countries that I've been to Korea last year, Japan, they're successfully using screen and treat, but only in the high risk population, Asian, Māori, Pacifica. We really need to update resistance profiles so we know what's going on, particularly with immigration from other countries. And my dream here is that we'll have PCR testing where we don't have to culture these pathogens for 10 days. So you could do a stool test and then you'll get a result in your inbox with the resistance profile like you would for any other bacterium that you do a swab for or otherwise. So ladies and gentlemen, H. pylori causes many symptoms. It's highly inequitable. It does require your index of suspicion and focus on ethnicities in particular. It will require a lot of effort to identify Māori, Pacifica and Asians. Stool test is the way to go. Treatment is 14 days. Anticipatory guidance is really helpful if you can eke out that time to help folks, in particular telling people that you will feel sick. Please do retest. If you have any questions, I'd love to hear them. There's an article that I wrote for New Zealand Doctor last year, which is in more detail about this. But I'd love to hear your questions and thoughts about this. Thank you.
So we do have a few questions coming in. I think we'll just start off firstly with, can you just clarify where the infection comes from, how it's transmitted, a little bit about that?
Yeah. Then very good question. The reason I didn't have it in the talk, and I was hoping no one would ask, is because if you look it up or ask ChatGPT or otherwise, we don't we don't know. It's probably fecal oral contamination, but really interestingly, we don't know. We don't think, we know that it's very much far now spread, probably within the family, which is why many Māori Pacifica are sort of worried about their kin when they get diagnosed with this. And but we don't know for sure how it's spread. We don't know. We presume it's fecal oral and related to hygiene, especially because the reinfection rate is low in first world countries. Probably fecal oral. I have had some patients who have refrained from eating together as a family or engaging in intimacy afterwards because of this diagnosis. I really tell people to not worry from that point of view, but in short, probably fecal oral.
Someone's just asking a question around ranitidine and that it was stopped in New Zealand because of cancer risk. Is this still your understanding, even though you said it's coming back to New Zealand?
Absolutely.
The benefit of ranitidine over famotidine.
Yeah. So no difference really between ranitidine and famotidine. As you know, with H2 blockers, there is quite a lot of tachyphylaxis, meaning once you sort of take it for 1, 2, 3 days, it works very well, and then the efficacy of it wears off. If you stop it for a week and then start taking it, it starts working again. Ranitidine, as you've correctly mentioned, has been taken off for worry about cancer risk. The company has gone back and they've fixed that problem, and so the current my understanding is that it's been sort of put back through Pharmac and things, and it's been accepted. So I think in the next couple of months we'll probably see ranitidine back on the shelf. No difference between ranitidine and famotidine. Patient preference, prescriber preference.
Are you supportive of the asymptomatic screening in high risk population?
That's such a good question. Look, I went over to other populations where this has made such an enormous difference. It's been a real population health celebration. In New Zealand, our prevalence of H. pylori and gastric cancer rates in high risk populations, Māori, Pacifica, Asian, absolutely justify this. The QALYs, if you want to put it that way, quality adjusted life years, for screening in high-risk folks is about $8,000 per person per treatment. It's very low when you compare it to other treatments. I think it's going to be massive bang for buck. I hope in my career that we're able to push that over the line. I published a recent article this year about sort of putting together all of the evidence why that would and should be something that's implemented in New Zealand. It'll be my life's work to get that over the line, along with a big group of other motivated folks. A lot of my PhD is to try get that basic information to make that a possibility. And that means getting the treatments right, the resistance profiles right, the first line treatments right, because the last thing I would want to do is cause more resistance, cause more troubles for patients, especially difficult to convince some folks who've got no symptoms to take 14 days of tablets that are going to give them a 10 to 20% chance of making them feel sick when they didn't in the first place.
Yeah, interesting. And in regards to that, so when we see someone who is positive, do we need to be checking the rest of the household, or the community that they're living in? What's the thoughts around that?
The current sort of guideline evidence is to just treat the symptomatic folks. I would ask patients if they have family members that might be symptomatic, and it would be absolutely reasonable to test them. They may talk about children less than 18, absolutely not. Really do your very, very best to talk them out of it. The risk is very, very low. Even interestingly, in pediatrics, even patients, for example, with iron deficiency and abdominal pain, young children, even if they did have H. pylori, it's highly unlikely that it was related to that. H. pylori, very indolent in children, although probably the bacterial infection is picked up when you're very young. So I think that what we will branch out to is in high-risk patients, high-risk ethnicities, those with a family history of gastric cancer or the high-risk ethnicities mentioned. I think it would be reasonable and probably going to be recommended to treat family. As it stands, I would ask folks about dyspeptic symptoms and go on that basis, and definitely avoid treating children if possible.
You mentioned that there's a large proportion of people who will be asymptomatic with it. So how do we capture I mean, I know what you mean about screening, but I guess how do we capture those people who are at higher risk for cancers?
Yeah. Patty, that's the crux of the whole thing.
Mm.
And why this is so difficult is that there's such a divergent response. Most people will have nothing. Some people will develop horrible cancer. And, of all the gastric cancers, well over 90% in New Zealand, H. pylori related. How do we know about those folks? I think in the future, it's probably going to be, circulating tumor DNA, some other interesting testing. It's very difficult to develop an H. pylori vaccine, which will put us all out of business, and that would be great. We don't know. You do have to take a bit of a brush cutter approach to it, which is a shame, which is sort of makes it more difficult and more of a difficult sell for folks. But don't forget that H. pylori, I think, is not all just about gastric cancer. That's the worst sequelae. But absolutely, every day I see a lot of symptomatic patients, dyspepsia, abdominal discomfort, ulceration. There's a number of other conditions associated with it, iron deficiency, ITP, rosacea, that are also important and are improved with treating H. pylori.
There's quite a few questions regarding if the quadruple, like they've gone triple therapy and then quadruple therapy, and if that fails, what's the next step?
The next step for that is referral to hospital. And at that stage, the specialist there should do a gastroscopy, which will be nice because they'll be able to see inside the stomach and make sure there's no worrisome features there with regard to gastric cancer or early gastric cancer. But also the purpose of that would be to do biopsies from inside the stomach. These biopsies are then cultured, which takes 10 days to grow, and they do antibiotic resistance profiling on the culture, and then treatment provided. There are other medications, fluoroquinolones in particular, moxifloxacin, that can be given for very resistant organisms, and we're seeing a little bit more of that in Auckland now with immigration, and antibiotic use overseas with less antibiotic stewardship. So third line, if you're not there after first line therapy and second line therapy, refer for gastroscopy, biopsy, and culture.
Okay, interestingly, we've had a couple of people say they've gone through that process. The biopsies have come back negative, but the stool is still coming back positive. So
Yeah, great question.
yeah, interesting.
And the answer to that is that it's very difficult to grow Helicobacter pylori on an agar plate. It's highly likely that the biopsy is probably, it's possible that it's a false positive, a false negative, but usually the bacterium in the stomach has been knocked back and will regrow, and it's sensitive enough for the fecal antigen to pick up, but not for the biopsy and to grow it. And so the bacteria has been suppressed but not killed. We're going to do a trial here of all of the folks that have got negative biopsies for Helicobacter pylori, and then we're going to submit them to PCR. And we overseas 30% of patients with dyspeptic symptoms that have a gastroscopy, that have a biopsy that's negative for H. pylori, that then have a PCR test are actually positive. So that makes me a bit worried, but we need to reciprocate that in New Zealand. So that's a tricky one.
Can I just check? There's a couple of questions around retesting, and I think there is some, I guess, different information regarding that. So would you recommend retesting everybody to confirm?
The short answer to that is yes. The current guideline in Auckland, and it's sort of different in other areas throughout New Zealand, is only retest if the patient has ongoing dyspeptic symptoms. Like I said, I'm working very, very hard, and we've written a big sort of position paper and are submitting that to make sure that the lab tests and folks are sort of in agreement for this. But I was talking to infectious diseases specialists and a few other folks, and if you have a WHO class 1 carcinogen, which H. pylori is, an identified bacterium, and we think that probably 80% of first-line treatment is effective, triple therapy, 80%, so 20% will fail first-line therapy, and you're not rechecking to see if this has been eradicated, is frankly probably unacceptable, and in other countries is mandatory. So my feeling, if you really wanted to follow the rule book as it stands, definitely recheck dyspeptic folks and recheck high risk folks, Māori, Pacifica, Asian in particular. You'll see from that data that many other patient groups are already being retested anyhow. But my sense is that this is going to change and absolutely should, and I support retesting absolutely.
Thank you so much, Cameron. I really appreciate your time tonight. We are now going on to our next topic, which is the Fit for Symptomatic Pathway, and that will be presented by Doctors Ralph and Dalen, who's a colorectal surgeon at Waikato Hospital. He's been involved with the bowel screening program since its inception. He's currently the chair of the National Bowel Cancer Working Group and has been involved with developing the Fit for Symptomatic program. Dr. John McMenamin is our Whanganui GP. He's the primary care lead for the National Bowel Screening Program, and he's been actively involved in the program's implementation and has led recent primary care campaigns. He also holds the role of primary care lead for the Fit for Symptomatic project, focusing on enhancing patient care pathways for bowel cancer. Thank you so much.
I'm going to begin by talking about bowel screening. You're all familiar with that. It's been successfully implemented in New Zealand. It's focused on the 60 to 74-year age group, and it picks up cancer very well. I'd just like to highlight the staging that we pick up within bowel screening. And the symptomatic population, stage 1, it's about 11%, but within the bowel screening program, it's 39% plus. It is for the asymptomatic population, and the basic test is the FIT test. So what about for the symptomatic population? The major issue is we need to rule out bowel cancer, but there is a problem, or a number of problems. And Firstly, the clinical estimation of bowel cancer risk is actually very poor. So colonoscopy has been used increasingly, and as a result of that, endoscopy services are overwhelmed. So this has resulted as a result of investigating patients with bowel symptoms and with bowel screening. We're doing huge numbers more of these colonoscopies. But a large number of colonoscopies are unnecessary because few of those with bowel symptoms are likely to have bowel cancer. So this is where the FIT test comes in. It's already being used. GPs are familiar with it. And it can be set at different sensitivities. For the bowel screening program, it's set at 200 nanograms of hemoglobin per ml of buffer. So we can use this to identify those with high or low risk of cancer. The high sensitivity is above 750. The low sensitivity is between 50 to 75, and they both produce a positive FIT. Below 50, the test is inaccurate, but it helps to identify those who are at very low risk of bowel cancer. So we've been looking at the experience within New Zealand, and we've done a trial within the Waikato and Waitemata areas in 22-23. We looked at patients who were already booked for colonoscopy, and just under 1,200 completed the FIT test, and about 1,043 went on to have a colonoscopy in the public system. 1,500 did not proceed with it because of no symptoms, or they went through the private setup. So participation rates are listed: European, Asian 84%, Māori Pacifica in the low 70%. So if you look at the New Zealand experience, those with a high positive, i.e. above 750, which this made up about 6% of the total group of patients, 80% of the cancers were found in this group. And to identify those cancers, we needed to do 3 colonoscopies, or 3 patients to identify 1 cancer. When it came to the low risk patients, they make up about 14% of the total number of patients, and they picked up a further 11% of colorectal cancers. And the number needed there to scope was 7. When it came to the negative test, this was found in 80% of patients, and a further 9% of cancers were identified, but 280 colonoscopies had to be done to identify 1 cancer. So 9 out of 10 cancers had a positive FIT, and you'd need to do a large number of colonoscopies to identify those with a negative FIT and cancer. So the FIT test really helps to focus on those most likely to have cancer, and it really speeds up identifying those with colorectal cancer by reducing the number of unnecessary colonoscopies. If you look at our diagnostic accuracy, it's much the same as international studies. Sensitivity 91%, specificity of 83%, negative predictive value of 99.6%. The UK has had a lot of experience using the FIT test. There was certainly one study which has shown that those who had a negative FIT and then went on to be diagnosed with cancer, the median time to diagnosis was 2 months. And UK hospitals have used the test to prioritise patients for colonoscopies and reduce the backlog of colonoscopies. In primary care, there has been identified the need to use it there, and ultimately that's where we see it being used in New Zealand. The National Bowel Cancer Working Group, which provides oversight of the bowel screening program in New Zealand and planned care, were tasked with designing the pathway for the symptomatic patients to undergo a fit test and identify those at the higher risk of bowel cancer. And at the same time, also manage those who are at very low risk of bowel cancer. And also consider safety nets as well. So in 2024, we set up and developed the pathway and set up the registry. In 2025, we plan to trial it in 5 districts. So this is the pathway as we've planned it out. I'd just like to point out that Primary Care Advisory Group has been involved. So patients are referred for bowel assessment, not for colonoscopy, but for bowel assessment. And they're referred by GPs, as you normally do, into the hospitals, and then they'll be triaged. So new symptomatic bowel referral will be triaged to the FIT pathway. Some will go directly to colonoscopy as they have, some will go on to clinics. Now, those who are already on the non-urgent wait list will also be put through the FIT process. So they'll be entered into the FIT for symptomatic register. A letter with a FIT kit will be sent out to the patients. Those in the priority population will get a phone call to encourage them to complete that promptly. Hopefully, all patients will complete it promptly, return it, it'll be tested, and then the register will notify the districts of results. So those with a high FIT, it is expected that they will get a colonoscopy within 2 weeks. Those with a FIT between 50 to 749, they will be placed on non-urgent list and ideally be done within about 6 weeks. Those who have a negative FIT will be declined a colonoscopy, and they'll be advised to see their GP, particularly if the symptoms are worse or if their symptoms persist more than 6 weeks. You'll see that there's the spoil kit process, which is the same as for the bowel screening process. And you'll also see that those who don't return it readily by day 15 or by day 20 will be followed up with calls. Those who don't send it in within 30 days will be placed on the non-urgent colonoscopy wait list. So the FIT pathway for the symptomatic patients will focus on new referrals, priority patients on the non-urgent wait list, and then also on the non-urgent wait list where there'll be a phased implementation. Patients from 16 years and onwards will be able to do the FIT test. A negative FIT test, as said, patients will be declined a colonoscopy unless the grader initially has said they proceed to otherwise a clinic or non-urgent colonoscopy. A not returned FIT kit by day 15 or 20, patients will be contacted at least 3 times. For priority populations, up to 5 times. And if not returned by day 30, they'll be placed on a non-urgent wait list for colonoscopy. So priority populations will also receive a phone call to try and identify any particular needs and encourage them to do the test. So the implementation will be first in 5 districts. These are the districts which have the largest bulge, as I call it, of patients who are waiting on this incredibly long list. Waikato will be first to do it, to enable testing and really look at any fixes that we need to do to the register. The go live date will be around June this year. It still needs some integration with the Clear system, and throughout the pathway we'll be looking at testing it, trying to improve it, and help with preparation for the rollout. So safety netting, this is obviously critical, and I'll ask John to step in here with a few comments.
Yeah, thanks, Ralph. This is a very exciting program and great that we've had primary care involved in developing a program. So as GPs we're obviously quite concerned not to miss cancers. And we'll be referring using the same criteria that we currently do, but some of our patients with negative FIT results are going to be discharged after referral without a colonoscopy. So that's the main change from our perspective. So the safety netting advice for patients discharged includes a recommendation to return for further assessment if symptoms persist. So there's no need for us to actively check in with patients as a routine. That's not a responsibility that we have to have. But of course, that doesn't stop us from doing that if we think that it's indicated for particular patients. So the information provided to patients, the main shift for us as GPs in our thinking is that we're referring for investigation of symptoms, not for colonoscopy. So patients have access to a patient information sheet. We will have access to that sheet. It'll be on the health pathways, and we are hoping that that will be there with a QR code so that patients can have it on their phone as well. And we'll advise patients being referred that they'll be triaged at the hospital by a specialist, and with one of these options that's outlined on the information sheet here. They're either going to be placed on a wait list for colonoscopy, or they're going to be seen in clinic by a specialist, but most likely they're going to be asked to complete a FIT test. So these options are going to be reinforced on this patient information sheet available on the health pathway, and that will allow us to share that information with the patient so they're very clear that they're being referred for symptom assessment, and that may not include colonoscopy. If they've already done a FIT test, they're going to know what a FIT test is about. So if they've been in the screening program, they'll understand what is involved in that. If they haven't, we will need to explain to them what a FIT test is, and we will be able to share a link to how to complete a FIT test. That's very readily available on the Healthify web information service and several other places as well, and easily identified through searching, showing people actually how to complete a FIT. So the patient letter that will come on referral will come from secondary care, and patients will receive instructions on the FIT from the hospital by letter, explaining to them how to go about that, and that a FIT test will be sent to them and how to proceed with that. And then the follow-up that Ralph has outlined, supporting all patients, but particularly priority group patients to do that test. And then if we can move on to the discharge letter. So for those who are testing FIT positive, then they'll move on most likely to colonoscopy. If they're FIT negative, they won't need a colonoscopy, and they're going to receive this discharge letter, which is going to advise them that if symptoms persist, please return to their GP after 6 weeks. So they'll be well advised by that process, but we can also advise them that at the time of referral, we're referring you for symptoms. There are some options. Most likely you'll have a FIT test. If that FIT test is negative and your symptoms persist, then you need to come back to us.
Brilliant. Thank you so much for that. Okie dokie. So there's quite a few questions just around the implementation of the FIT test and I guess the cost of them, and why would we not be completing the FIT test before referral to the pathway or to the hospital?
Derek, would you like to pick this one up?
Yeah, sure. So I think the question is really around, why aren't we doing this in primary care directly rather than using this process through the districts? And certainly, I think in the long term, the plan is to, when we roll this out nationally, for it to be a community and primary care pathway. But this initial implementation is through the districts, and will be an opportunity really to evaluate some of the issues and around how we're going to roll out the community pathway. So great question, and logically that is going to be the way to go. But unlike a lot of other tests, it does involve actually having a kit sent out, and there's also a recommendation where you have a single lab to improve the accuracy and quality. So that's a little bit trickier when you're having to use a single lab and have results go out across the Aclare network. So this implementation is going to allow us to really evaluate how we're going to do the community pathway.
just checking in, when you say symptomatic, what sort of symptoms are part of that? Is diarrhea more predictive than constipation? Who are we referring, and what sort of bowel symptoms?
By and large, it's just those in whom it's just the standard sort of approach that we've used for referring patients in with any bowel symptoms, abdominal pain, PR bleeding, diarrhea, and so forth. And I guess the referral process doesn't change to what's happening at the moment. So it's much the same as what we're doing at the moment with the referral through to colonoscopy. But again, I sort of just stress it's not for colonoscopy; it's for a bowel assessment.
And for the regions that aren't part of the pilot program, will they be able to do a self-funded? Is there any way that they can access that, or it's just within those pilot regions at the moment?
We certainly want to get as much information as we can from this implementation in 5 districts. There are a number of other districts that are very keen to set this up as well, because they have major colonoscopy waiting list pressure. And there's a little bit of discussion now about how they could maybe be early adopters of this pathway. But what we're also trying to reassure them about is we want to get the community pathway set up, designed, and ready to roll out as soon as we can. So we're hoping that that will be the way other districts will be able to be part of this.
What about the self-funded faecal occult blood test? Does that fit in? Is there a threshold for positive results, high or medium risk within the local lab? Or
I guess, Derek, there's probably not going to be a place for it because, as Derek mentioned, you really have to have one lab doing the test and maintain that quality. It's the same thing as for the bowel screening program. We said early on that we would not be accepting tests which were outside of the program. So the plan is to stick with those that are requested within the program and not without at this stage.
And in terms of the areas that are going forward with the pilot in June, what advice should GPs give to the patients who have already got a national bowel screening kit at home if they haven't completed it? Would they come back and get a fit test, or what would they be picked up and sent a fit test? What's the plan there?
Yes, we've spent a lot of time working through this issue, of course, because obviously there's a risk that people would get 2 tests and they have different sensitivities. So if somebody, so the program, National Bowel Screening Program, will have the opportunity to switch off referring for people who have been referred for symptomatic assessment. But of course, there still could be an overlap period. It wouldn't matter if people do both tests, but what is important is that they do the symptomatic test, because that's the one that is set more sensitively. So that is being taken care of at a systems level. But if there is any overlap or other concerns, the one that needs to get done as a priority is the symptomatic one. What we want to make sure, though, is that people don't mix and match their kits if they have them at home, but that they hold them together and do the correct one.
Brilliant, thank you. And how recent is recent enough for a negative bowel screening test to be considered as relevant to this process? Or would everyone repeat?
Not relevant at all. So that just once screening an asymptomatic population, the other one is investigating symptoms. If someone has symptoms, then they need to go down a symptomatic route. We assess the symptoms in the same way that we normally do. We've got reference to the direct access colonoscopy criteria to understand what the symptoms that are important are. And if they meet those criteria, then we would refer them in the same way. But of course, it's not for colonoscopy, it's for bowel symptom assessment.
Thank you. Are there plans for the information sheets to be available in other languages?
Yes.
Yeah, brilliant. We can't directly request fit tests. Is this something that will eventually happen, or?
So that's the intention, yes.
Yeah.
Yeah. So we'll get considerable information and understanding, not just about the testing, but also about all of the other issues that are required to have a quality program associated with this. And then this test will become available in primary care.
Are you also planning on using the high threshold, normal threshold difference in the National Bowel Screening Program, or is there no place with the quantitative?
No. No, so that is a asymptomatic population screening program with a set level, and it's a very effective program. It's working very effectively, and we want to continue that. What we want to do with that program is just increase the equity outcomes by encouraging everybody to have conversations with their Māori and Pacific patients and the other groups that are having low engagement. And we're going to have another campaign later on this year in May to encourage that to happen.
With the FIT test, it gets sent to patients by regular post or courier post, and who's liable if it's lost or delayed in the mail, or is there anything that we need to consider in that respect?
I'm not 100% sure about the post as to whether it's courier. I think it's the same system as used by bowel screening. So part of the process, though, is that if the kits aren't returned and completed, then the patients are contacted, and so that's an opportunity to identify that there's been a problem with getting the kit to them. So there's two opportunities that they'll be contacted at 20 days and 30 days to try and make sure that they can get a kit completed.
This is an opportunity for us to update contact addresses, of course, and ideally that's happening routinely at our reception level, but it's still a great thing when you refer somebody to double check the address is correct.
Brilliant. Okay, well, thank you so much for joining us tonight, and we are now moving on to our next segment, which is clinical updates with Dr. Tutty, who's a GP and primary care advisor here in Tamaki Makaurau.
So quite a few things to talk about tonight, so I'll just get started. The first one I wanted to just make you aware of is that there has been an increase in cases of HIV in Fiji, and these are being seen in New Zealand as well, so just to be aware of that. And there have been some cases of HIV in pregnancy, so that if you feel that a person is of high risk, it may be worth repeating a screen in the third trimester. And while we're talking about STIs, we're just wanting to remind everybody of bundling, that if you are doing screening with swabs, please remember to add in the blood test, the syphilis and HIV test to go along with the swab tests. And if the hepatitis B status is unknown, then check that, and hepatitis C if there's any risk factors. If there's discharge, then to take a swab for gonorrhea so you get some sensitivities, and if there's genital ulceration, to do the herpes swab. Prescription subsidies cards is another thing that has changed. This will be finalised at the end of March, but even now there will be a new way of recording people's prescription items so that they don't have to go back to the same pharmacy every time, but can use multiple pharmacies. And this will now be linked to their NHI, so it will come up with their prescriptions and they won't have to keep their cards or go to the same pharmacy. It's a little bit messy. I think, as you know, that the prescription subsidy cards turn over on the 1st of February every year. So between February and March, we've still got some cards in use, but from March, it's all going to be automated. So that's great for our patients and gives them that flexibility with the pharmacies. The Health Pathways team has asked me to remind you of a few things. So one of them is their funding and subsidies pathway. I talked quite a lot about this in November at our session there, and there was some feedback that it wasn't completely live across New Zealand at that stage. We're working on it. It is now live in 3 sites, and 7 others are working on updating it for their region, and it will be live shortly. But there was a great deal of work that went into this piece of work, and particularly working with MSD to get all the funding opportunities out there so that primary care would know about it. So there's primary care funding, national funding, patient accessible funding, it's short-term, long-term, one-off, all sorts of details there. And it's particularly for health professionals that are new to New Zealand. So one's new to primary care or not sure of our system. If you could point them in the direction of this pathway. The other one that's now been adopted across New Zealand. I think every pathway in New Zealand has this, is the Continuing Medical Education and Professional Development site. So it's on the home page, which you can, so if you see it down there where I've put the red arrow as the place to go. It's really quite interesting. When I was preparing this talk, I had a look on it and signed myself up for a talk that I didn't know was happening. So do make use of that. There's been a lot of work on ADHD, and I've talked about it at these sessions on multiple times now, and there's more in our Pharmac section tonight. But you will remember that from the 1st of December, the special authority for prescribing the medication has moved to lifelong rather than requiring a renewal every 2 years. And there's a new medication that's now funded, the lisdexamfetamine. So there's also information to learn about that. And one of the pathways that has been updated, just to provide you a bit more guidance for this, since we're now going to be managing the medication long term for people with ADHD, is the pathway for children. There's actually 2 pathways for children and youth with ADHD. There's a main pathway, but there's another one that I wanted to draw your attention to, which is the medications section. We all know that medication is usually the first line because it's been proven to be efficacious. So that for moderate to severe symptoms, that's what we all move to first. But don't forget to have a holistic approach for children, that it's important to know what's happening at home, what's happening at school. There's great information on this pathway, taking a history, on divergence, which is just making sure that the medication is getting to the right person. So things like checking how many different people are prescribing the medication. Are they prescribing multiple doses of it? Just to have some safeguards on that. And a big section on managing side effects for people, which on the whole aren't major for ADHD medications, but good to know about. So, Pharmac section. Good news, quite a bit of good news tonight from Pharmac, really. Desogestrel went out for consultation. The consultation's now closed, but we're expecting to have a finite decision by the 1st of April. And if all goes well, that desogestrel, or Cerazette, as most people will know it, will be funded from the 1st of April. So I thought I'd just give a little bit of information about Cerazette. It'll be available on prescription and on practitioner supply order, and it'll be dispensed in 6 monthly amounts, just like other funded contraception. It's a progesterone-only pill, so a mini pill doesn't contain estrogen, can be taken at the same, it should be taken about the same time every day, but it has that 12-hour window, and it's continuous without breaks. So it works on the cervical mucus to make it hard for the sperm to get through and to prevent ovulation. And of course, as we know, it doesn't protect against sexually transmitted infections. And it's used by some people for other conditions, but they're not MedSafe approved, so you'll need to follow the indications. If you don't use it for an approved indication, you need to follow Section 25. So the rationale for moving to Cerazette is that it's more effective at stopping ovulation than the other funded progesterone-only pills. It's got more flexibility for a missed dose because you've got that 12-hour window instead of 3. And also that there have been supply issues with the currently funded products. So that's microleutin Noriday that I think we all know have been around for a long time, but there have been problems getting hold of it recently. And like the other mini pills, it can be used when breastfeeding. I've been asked to give just they've had a number of inquiries to Pharmac on empagliflozin, and it's caused a little bit of confusion. So just to clarify that, empagliflozin now has a special authority to use for people with heart failure. We know that for diabetes, we're not allowed to use both dulaglutide and empagliflozin together, that it has to be either a glutide or the empagliflozin, but not both. So if you do find that your patient qualifies to be on both, then it's possible to use the empagliflozin in any form or any dose, and even empagliflozin in combination with metformin is possible, even if their special authority is for heart failure. Another good news story, liraglutide is now got enough stock for to be able to meet the demand, and so the eligibility criteria has gone back to being available for anyone. It's not the no new patient restriction anymore. So that's good news that we can start using that for our people with diabetes. Dulaglutide is not at that point at this stage and is still restricted to existing patients only. Cilazepro, I hope it's the last time I talk about this. It's stopping on the 1st of March. Apparently there are still about 200 patients still taking Cilazepro. So if you have any patients still on Cilazepro, please make sure that they're moved to one of the other alternatives. And again, I've put the dosing in of these alternatives so you can transfer them over. And back to our problems with methylphenidate. So there is a global supply issue. So it's really outside of the control of Pharmac that they are looking at all available options to solve this. We've been saying that it's particularly with the extended release preparations, but as we're starting to use more and more of the other preparations, then they will become in short supply as well. Legally, patients can be changed from one formulation of methylphenidate to another, providing there's a valid specialist recommendation that was made before December 2022. So in December, the special authorities rolled over for everybody who had a valid special authority at that point. So it stays that at that point, it becomes lifelong. So that date of December 22 won't change. So advice for prescribers, do not start people with ADHD on extended release preparations unless it's really necessary. Please prescribe generically so pharmacists can change between brands. Have a chat to the patients when you're renewing their supply. It may be that they don't require to take it at the weekend, and therefore we can make our stocks last a little bit longer, but obviously that's a clinical decision. And there's advanced warning that Pharmac is planning to do a Goodfellow webinar on the 1st of April, so there'll be more information about this topic then. And I'm now come to the last section of my talk where I just like to give you some warning of things that are being talked about that may well come to pass. I'm not saying that this is happening at the moment, but it is certainly in the pipeline. And tonight I wanted to talk about maternity ultrasounds. I think everybody knows that it has been an issue across the country. There is a proposal to fund only clinically indicated ultrasounds. Now that might sound strange to you, but actually the clinically indicated ultrasounds are very clearly defined as the 12-week what we're now choosing to call the early anatomy scan, or used to be the nuchal translucency scan, and the 20-week later anatomy scan. And then later scans as clinically indicated, such as for growth or for other clinical reasons. So the advantage of this is to free up appointments for clinically indicated scans, to divert funding to those that are clinically indicated, to reduce the anguish created by scans that are done too early to confirm viability. And we see this quite a bit where people go in as soon as they discover they're pregnant, they have a scan at 5 weeks that can't see a fetal heart. And there's a whole lot of consternation until they've had another scan, yet another non-clinically indicated scan that shows them a heartbeat. So we're also putting a lot of demands on whānau to turn up to these scans and to try and book them, which really is not necessary. And certainly this change in the model of care will be challenging. There's a lot of consumer expectation to get an ultrasound at the very beginning of their pregnancy. And it is a bit different to the previous guidance that people might have had. But there is some rationale behind this, that you can get some idea of the size of the pregnancy, and certainly the uterus is palpable from 12 weeks. So if you can feel a uterus, you've got some a fundus, you've got some idea of gestation. A 6-week scan, yes, is more accurate than a 12-week scan by 3 days. And we're just thinking that the 3 days is not enough for all the difficulties that are involved with having those early scans. And yes, a scan over 20 weeks is less accurate, but we're not suggesting that. Any questions?
Cool. So we do have some questions coming in. Thank you so much, Sue. So just in terms, can someone just ask if you can just clarify what you mentioned about the SGLT2s and the GLP-1s, RA, sorry. Can the SGLT2s be prescribed if someone has heart failure, but also GLP-1 RAs if they also have type 2 diabetes?
Yes.
Brilliant. Lovely. And lots coming in about the maternity scans, which is great. So maternity scans, what about if they're not sure of their LMP? So sometimes we do dating scans. Would that be covered under that?
Oh, that's exactly the scans that we're wanting to stop.
Yeah.
There is no place for dating scans. If they really have no idea, then I think that you should lay a hand on their tummy.
Yeah.
And if you can feel a uterus, a fundus, then you know that they're 12 weeks or above. The fundus is usually at the umbilicus by 20 weeks is another good measure, and you can sort of calculate somewhere in between. Even on our large woman, it's usually quite easy to feel a fundus at 12 weeks. Sometimes,
Oh, no, sorry, carry on.
yeah, sometimes you might need to hold up the pannus and feel underneath that, but the fundus feels very firm, and I think that clinically it's quite possible that if we get that nuchal scan at approximately 12 weeks, that's a good way of estimating the gestation.
For those patients who are very sure that they will not be proceeding with the pregnancy, do they still need to wait? I mean, there is that. In that situation, surely a dating scan, even without LMP, would be clinically indicated if it was going to be causing distress.
Actually, scans aren't required for abortion services. A beta HCG is required for most of our abortion services, but a scan is not. If there is concern about dating, then most of our abortion services can do scans at the service.
And for those that are high risk or query ectopic or anything like that, that would be covered under that clinically indicated.
Absolutely. If they've got abdominal pain and you're worried about an ectopic.
Yeah, brilliant.
if it's clinically indicated.
Okie dokie. So that is all we have time for tonight. Thank you so much again to everyone for joining us. And thank you so much to our speakers. It was a real privilege to hear you all speak tonight, and I really appreciate all the resources and knowledge that you've shared with us. Have a lovely night, everyone. Ka kite.